So I think the first very important thing to emphasize is that when faced with a progressive MS patient, and I think primary progressive is a great example because they begin with gradual worsening of their disease, you never want to take away hope. And I think it's very important to look for comorbidities. That's been a major theme because those are, correctable. Is the patient following a wellness, health maintenance, vascular risk factor program? Because if they're not, they're harming their central nervous system, so you want to counsel them about that. You really want to look at their MS symptoms and make sure that you've optimally treated that. And then I think you can also speak to the progressive MS patient that even though there's no approved disease-modifying therapy yet, there have been very positive findings, and we may have treatments in the not too distant future. I think the best scenario for the patient is that their physician feels comfortable with the disease. It would be very nice if every MS patient had easy access to a comprehensive MS care center. That's just not going to happen in the United States, at least certainly not for a long, long time. So the issue is, how comfortable does the neurologist feel with regard to evaluating and taking care of MS patients? If they do, they have an interest, they've kept up, then I think that that's fine, that's perfect. If they don't, then it would be good if they could find someone in their area who really perhaps has a passion and a greater interest in MS. I would certainly expect that a physician that was knowledgeable about MS would be knowledgeable about both the relapsing and the progressive forms of the disease. I think the most promising thing to tell MS patients is that there has been a phase 3 trial in the pure progressive form of MS, primary progressive. It's called Oratorio, that for the very first time met its primary outcome in slowing EDSS progression compared to placebo. And this was the phase 3 trial with ocrelizumab, an anti-CD20 that knocks out B cells given intravenously twice a year. So I believe that the packet has been presented to the FDA. Once accepted, the FDA has fast-tracked it because there is no current approved treatment for progressive MS. And they have said that they will give an answer within 6 months. So we're expecting to hear about ocrelizumab by the end of this year or early 2017. And remember, they had done a total of 3 phase 3 trials, 2 in relapsing MS that were very positive, as well as the phase 3 trial in primary progressive MS. So they're going for approval in both relapsing and primary progressive MS. That's going to be a very interesting question. They did not have secondary progressive MS patients in the study. They only entered primary progressive. I think it will be very interesting to see what decision-making the FDA does. The current thinking about progressive MS is that gradual worsening is the clinical expression of neurodegenerative injury to axons and neurons, and that basically you're talking about a similar, if not identical, process with primary progressive and secondary progressive MS. So if you take that approach, then any treatment proved to benefit gradual worsening progression should be applicable to both phenotypes of MS. Whether the FDA will endorse that or not, I don't know.